with your small community or critical access hospitals. So I don't think they liked that. I don't think that was fair to you guys either. So what they've done is to try to address concerns about comparability of hospitals because size, volume, case mix, service mix are vastly different. What they've done, rather than actually take those characteristics and put people into peer groups, is that they're using the number of measures that are available as a proxy for peer grouping. So if you have measures in 3 measure groups, you're compared against each other. 4 measure groups, 5 measure groups. So what they do with, once they put you into the peer groups, is it's much more complicated than how I'm going to explain it, but essentially they take a bell-shaped curve and they do something called K-clustering. And if you're out on either end, you're either a 5-star or a 1-star, and then most of the hospitals are kind of in the middle of that. So what they're doing with that peer grouping now is that instead of having everybody in one big group, they're doing the grouping between, if you have 5 measure groups, you get compared against each other. 4, you get compared against each other, and 3, you get compared against each other, which I think in theory sort of makes sense. But what happens then is that almost 80% of the hospitals fall in the 5 measure group. 15% fall in the 4 measure group, and only 6% of hospitals fall in the 3 measure group. And the bulk of these two down in this area are critical access hospitals. So when you had everybody in one big group and you did the K clustering that would do the thresholds to have the cut points for which star you got, critical access hospitals almost never fell out in the 1 to 2-star range. But now you have this much smaller groups in the 4 measure and the 3 measure group that are being compared against each other, that are more predominantly made up of small rural hospitals. So we've seen an increase in the number of hospitals, critical access hospitals, that have received 1 and 2 stars, in part because you're comparing them to a smaller group. Does that make sense? I hope it makes sense. So I think in theory, the peer group is a good idea. I think what's happened is it has kind of had an outsized impact on small rural hospitals, in part because this is a little lopsided. Okay, so that's how the whole thing gets calculated. So they do update the star rating about once a year. They're not consistent on the timing, which is also a bit of a challenge. They have stated that the July 2023 will be the refresh. So, and they typically do that at the end of the month. And so that will be at that point, that's what will come up on the Care Compare site. So again, they aren't including the Q1, Q2, 2020 data. So some of those data periods are truncated. They do allow for a preview period, so you should be able to see your star rating typically about 6 weeks before it's published. So that preview period was May through June of this year. So there's a link here about how you actually can go and look at your hospital specific report. So if you did not see that hospital specific report in that preview period and it's no longer available, if you log into the hospital quality reporting site, you can ask for it. You can just email the quality help desk and say, I'd really like to see my preview report. Here's my hospital number. They will provide it. But that HSR is really important to help you understand how individual scores are impacting your rating. So always encourage people to take a look at that when they can. If you're not rated, there's not going to be, actually, if you're not rated, I'm not even sure if you get a report. To be honest, I can't see everything that you guys can see behind that hospital quality reporting curtain, but I would encourage you to go look at that if you haven't already. And I would note that because critical access hospitals are not required to report data through the inpatient and outpatient quality reporting program, you actually have the option to suppress your rating from Care Compare, but that has to happen during the preview period. So the preview period is just passed. So questions on being able to find or look at that data? Okay. So big picture, some of the changes they did for the methodology actually address some of the big picture concerns that people have had about the star ratings. but not all, particularly from a rural perspective. Less than a third of the critical access hospitals meet the threshold to have one calculated. And we've seen an increase in the number of 1 or 2 stars because of that revised methodology. So I like to think about the methodology as kind of like I like to bake, so kind of like a chocolate chip cookie recipe. So if you think about all the measures that are available on Care Compare as your ingredients, the methodology is essentially for how, the proportion and the order that you mix them together. So, chocolate chip cookies, pretty much butter, sugar, chocolate chips, flour, baking soda. You can mix those together in different proportions in different ways to get slightly different cookies, but it doesn't work very well if you are missing half of the ingredients. So what we were left with is a methodology that's using measures that a lot of aren't typically relevant for rural hospitals. So one of the biggest issues we have to kind of think about is how do we help ensure that there are rural relevant measures? And that's why it's also important to be sort of looking forward at what types of measure changes are coming that will influence future star rating calculations, recognizing that particularly if you look at that spreadsheet that I shared, the data that gets used for star ratings typically tends to be at least a year, if not 2 to 3 years old. So things that you're doing right now are likely to impact your star rating a year to 3 years from now. So there's a data gap or timeliness gap there. So I do want to share with you guys just a bit about some of the changes because there's actually been a lot of measure changes that have been coming out of CMS lately. So I kind of talk about it if there's really sort of been a shift in the landscape of how CMS has measures and is collecting data and measures. So let's just walk through a few of those. In particular, I'll try to highlight how some of these might impact future star ratings. So just a little bit of high level context. For those of you that have been doing this work for a while, you've probably recognized that there's kind of a regular changeover in the measures. They change on a regular basis. If you're new to this, I don't anticipate that will change, but just so you're aware, there's actually once a year, there is actually an annual rulemaking process that CMS uses that process to define what measures are included in different programs. So the inpatient prospective payment system rule defines what's in the inpatient quality reporting program, which critical access hospitals can voluntarily report those measures, but do not have a payment impact like larger hospitals do. The inpatient prospective payment rule also defines what's in the Medicare Promoting Interoperability Program, which critical access hospitals are held to. And then the outpatient side actually comes through a separate rule, different timeline, different group at CMS. And the outpatient rule defines what's in the outpatient quality reporting program. So if it ever feels like from a measurement perspective, there's a disconnect between the inpatient and the outpatient side, there is. I think they've gotten better over recent years, but it's actually run under a completely different set of people at CMS and a separate rulemaking process on a different timeline. So they've gotten better, but it doesn't always quite connect. The measures that get included are typically endorsed by the National Quality Forum and reviewed by a pre-rulemaking process. This has actually been a pretty big change just this year. The National Quality Forum has served in that role as what they call the consensus-based entity, I don't know, for as long as I've been doing quality work, at least 15 years. That contract actually shifted this year and went to Battelle Partnership for Quality Measurement. So what that process looks like is still kind of coming out. There will continue to be a pre-rulemaking process where there's opportunity for public input prior to CMS. So CMS will identify a list of measures that will get vetted and discussed by a pre-rulemaking process. Recommendations will be made. CMS can take those recommendations or not. And then CMS rolls out a proposed rule There's an opportunity for public comment, and then a couple months later, they come out with a final rule. So that's kind of an ongoing annual process. And so CMS regularly through that process adds, tops out, retires, or removes measures. I want to highlight the electronic clinical quality measure, the ECQM reporting requirements, because they are required for critical access hospitals as part of the Medicare Promoting Interoperability Program. That program has had a few name changes. So it used to be called the EHR Incentive Program, but most people actually call it Meaningful Use. So if you hear any of those words, they all mean the same program. So promoting interoperability, a lot of times people still call it Meaningful Use. That was the original kind of colloquial name for that program. If critical access hospitals aren't meeting a certain threshold of performance under that program, you are at risk for a financial penalty. There are lots of pieces to that program. Submission of electronic clinical quality measures is only one component. It's an annual cycle. So the 2023 data submission will be due in February 2024. And this is, obviously some of these reporting periods are past, but I left the history on here so you can kind of see the increase in what's happening here. So for the first 4 to 5 years that ECQMs were part of the reporting programs, you submitted 1 quarter of data and 4 measures. So you can see we've kind of sequentially increased here. For 2023, you submit 4 quarters worth of data on 4 measures. You get to pick 3, and then everybody submits the safe use of opioids. In 2024, it's again, you can't go to more than 4 quarters. So now it will be consistently 4 quarters worth, and they're actually doing 6 measures. So there'll be 3 that you get to pick, safe use of opioids, and then there's 2 maternal health related measures. If you don't deliver babies, then you won't submit those measures. So that's the ECQM reporting requirements. Here's the list of measures that are available. We still have some rural relevancy challenges with these measures. The ones that are in light blue, if you can see that shading, are sort of my take on what I think is relevant for most rural hospitals. There are several related to labor and delivery. If you deliver babies, those certainly would be relevant, but that certainly only about 40% of our critical access hospitals do. And most of these stroke measures, there are very few critical access hospitals that actually keep inpatient stroke measures. There's also a big move on behalf of CMS to start shifting some of these hospital harm measures into the ECQM format. I think it's super important to be tracking on these measures, but I think it's unlikely that most of you will hit the thresholds to have them publicly reported. And if they're not publicly reported, they're not part of the star rating score. So that's sort of a summary of what's happening in the ECQM space. Why that's important for the star rating is because CMS has indicated that they will start publicly reporting the results of those ECQMs. So for years, since ECQMs have been required, it's kind of been a black box. Can you get the data out of your system and into the CMS system? It didn't really go anywhere. Nobody was looking at it for performance. It just was more of a technical exercise. But CMS has now said they are going to start publicly reporting the data. They said that they were going to start with calendar year 2021 data. They've kind of taken their foot a little bit off the accelerator with that. At this point, they have said that they're going to include the data on something called the Provider Data Catalog. And so I have a link here to that in the slides. And essentially, CMS has a page where they post files. They post all of the data that goes on Care Compare in different files. So it's mostly like wonky policy people like me that go look at the Provider Data Catalog, or researchers that are looking at that. But it won't be, so your ECQM data will be released on that site, but it won't be released if I'm a consumer and I pull up your hospital profile on Care Compare. Your ECQM data won't be on that page at this point. So they have said that that is coming, but it's not there yet. They did actually include it in your preview reports. So if you look at those preview reports, they will start to have your ECQM performance listed. But at least at this point, they're not putting the ECQMs on Care Compare. And until they're on Care Compare, they won't be incorporated into your star rating. In addition to the inpatient ECQM, CMS added the first ECQM to the outpatient quality reporting program, again, voluntary for critical access hospitals. It's essentially a replacement measure for the chart abstracted OP2 and OP3, which retired after Q1 2023 reporting. So that reporting is due here August 1st. So that is an optional ECQM if your hospital wants to submit that. But at this point, they call it OP40 is what they're using for the measure. It does not align with the promoting interoperability requirements. So you can report it, but you can't count it as one of the 4 measures that you submit for promoting interoperability. Hopefully CMS will start to get that lined up in the future, but at this point it's separate. Phew, so that's ECQMs. There's also some hybrid measures that are going on that are rolling into the space right now. And so hybrid measures is where CMS is taking clinical variables that you submit and linking them to claims data. So it allows them to do a better job of risk adjustment for readmissions. And then they're also going to do this for mortality. So this is going to be for the all-cause readmissions and then also for the all-cause risk standardized mortality measures. So right now we're still kind of in a voluntary reporting period for the PPS hospitals, starting with data that's due next year. So starting in 2025, because there's always a catch-up period. Once this becomes the required hospital readmission measure for all causes, not the condition specific, they'll still have the AMI and the heart failure pneumonia that will be calculated using claims. But for the overall all-cause readmissions measure, they're no longer going to calculate that using claims only. So if you're not doing the electronic clinical variable submission, you will no longer have that calculated. For some of you might think that's great. I've been raising a little bit of a red flag about that because this is one of the more common measures that get used in value-based purchasing programs. So I'd encourage you guys to be thinking about whether or not you're going to participate in that voluntary submission of the clinical variables or what that looks like for you. Just wanted to give you a sense of what that means. This is the clinical variables that you would submit and the linking elements. The format is the same electronic format that you would use for your electronic clinical quality reporting. More measure changes. There's been a lot the last couple of years. So these are final rule changes. I have a few proposed changes that I'm going to share with you as well. So these are changes that have been made. So you'll start to see the COVID vaccination coverage measure will be included on Care Compare. So that will start rolling into your star rating report. If you do hips and knees, there is a pre-post patient reported outcome measure that looks at what patients report, whether or not they're better after they've had that hip or knee replacement. So that measure will be coming soon as well and be incorporated into that star rating. There's a hospital commitment to health equity structural measure that's coming that looks at how your hospital thinks about, addresses, has leadership focused on towards health equity. That one actually probably won't be included in your star rating. I should have taken it off this particular list because it's not a, so they don't include measures that don't have an obvious improvement or not. So they don't include structural measures basically. So this one you'll go in and you'll attest to some statements is what that will look like. There's also a health-related social needs screening measure coming. So it'll look for the percent of patients that you're screening for health-related social needs and the percent of those patients that are positive. There's a breast cancer screening recall rate. This is actually a claims-based measure, so it's already being incorporated onto Care Compare. So that's one of those that I encourage you to take a look at your hospital star rating. So they're looking at a performance score within a target range, and because that's claims, pretty much as soon as they finalized it, started rolling that out. So more detail about all of these. I have lots of links in here that will lead you to the sources for more detail on all of these measures. And then before we wrap up, my comments, I just want to share with you a couple of the changes that are proposed. So everything else that's new that I've shared with you is in final rule. This is what's being proposed. So the inpatient proposed rule comment period closed last month. The final rule will come out typically September-ish. A couple things that I think will be important from a star rating perspective, they have proposed changes to the HCAP survey administration. I don't know anybody who's against incorporating web-based options to the survey distribution. I think everybody's been asking for that one for a while. It is, 2023. Even my Medicare age parents will answer surveys online. So I'm optimistic that that shift will help increase survey responses. And if you are on that edge of sometimes having 100 and sometimes not, that might help you have enough response rate to get closer to that. There's a couple other wonky things connected to that. So there's going to be web-based options. They're going to allow a proxy to complete the survey on behalf of the patient. They're extending the data collection period a bit. A lot of vendors will add supplemental items to the survey for you. They're limiting that to no more than 12. And then this one I think is from an equity standpoint pretty interesting. They're actually going to start, or they're proposing to start requiring that when you give your data to the vendor, that you're actually capturing information about the language that this patient speaks. And if it's Spanish, that when they get administered the survey, they'll be actually using the Spanish version of the survey. So some process changes, I'm guessing, in terms of how you're capturing that and what data is going to your vendor to get the surveys out to help ensure that that happens. So those changes won't happen until 2025. If approved, they won't be immediate, but that'll be something that will be kind of rolled out over next year. Hopefully, some of that results in increased response rates. This first one is also pretty significant here. This is another proposed. They're proposing to expand the cohort for those 2 hybrid measures that I mentioned to include Medicare Advantage patients. So I think I said several times, and that was one of the chat questions, that all of the claims-based measures are only fee-for-service Medicare or traditional Medicare, original Medicare. People use all those names for it. So I feel like this feels like a crack in the potential to actually start incorporating Medicare Advantage patients in claims-based measures. So they have proposed it initially here just for this hospital hybrid wide readmissions and mortality measures. I'm assuming if that goes forward, there's the potential that eventually that will roll into other claims-based measures, but that should also theoretically expand the patient base. So when you're already kind of on small numbers, that might help allow additional patients to be included for you guys to have those measures calculated. They're also proposing 3 new ECQMs, the hospital harm pressure injury, there's one around acute kidney injury, and there's one around radiation dose for CT image quality. So more information on each of those if you guys want to look at those measures. So these again are proposed, not final yet. There's a proposed change in the vaccination, COVID-19 vaccination measure, talking about shifting it to be from up to date to complete. And then they're actually removing or proposing to remove the early elective delivery measure. Couple resources in the slides for you guys to find more information. And I think we still have like 3 minutes for questions. Comments. That was a lot fast.
I thought you did a really nice job, a really nice overview, and you may have went fast, but you covered a lot of territory. It was great handouts to take notes with too. So I appreciate you having this session and inviting us. I learned a lot, so I thought it was really good.
Thank you.
I would agree. This is Mariah. Hi, Carla. Thank you for joining today and giving us a lot of information. One thing that I learned new today was regarding the different group of measures and where we're compared on that bell curve. Did that change in April of 2021?
Yes.
With the methodology?
Yes.
When it changed with the
So
the different categories. That's what I was thinking when I was listening to your presentation today, because that really did, I think, impact some others as well. as if you even met one measure in that patient safety that could really pull you down with the star. And I can see benefits of both. But if you don't really understand that star rating and you see a larger hospital, a 5-star, and a critical access hospital, maybe a 2-star, that would be very difficult for a lay person to understand that.
Yep, I agree. There's
Yep,
some,
thank
we
you.
have, if they're going to, I mean, they've tried to do it with the peer grouping, but it's still not an apples to apple comparison because of the measures that are being used. There's so many gaps.
Right.
Yeah.
Yeah, because one chocolate chip in a cookie, I don't know if it really makes it a chocolate chip cookie.
Yes, an oops.
I guess it is a chocolate chip cookie if you like one chocolate chip in your cookie.
But it's better with more, right?
But it is better with more. All right, thank you.
Carla, did you mention, oh, great presentation, by the way. Did you mention the ECQMs to be in the current preview, or is it coming?
So it's not in, so I might have mixed and matched. So there's the HSR report, which would be the summary of what's going to be in the star rating that gets released probably next week. They're not going to be in that because they're not included in that yet.
Okay.
But CMS also quarterly sends out a preview report of what's going to be posted the next quarter on Hospital Compare. And so your ECQMs are now in that preview report, but they're not actually going on your hospital's site yet.
Gotcha. Okay.
Yeah.
Thank you for
Good
that clarification.
Yeah. It's a little confusing. And I was working with a hospital in Indiana and we were like baffled. They're like, what about this measure? And I'm like, well, they're not publicly reporting it yet. So I was digging through. Oh no, they just put it on the preview reports, even though it's not actually on the website yet. So I definitely would be encouraging you guys to take a look at those preview reports and your HSR reports. Yeah.
And I think one other resource that may be helpful, at least for my brain, to bring it together. So the IPPS proposed rules and the other, what has been final, even though we voluntarily report, the measures that are, a few of those measures that you mentioned, even though we would voluntarily report it, are not required for critical access hospitals. If we wanted to be included in the star rating, we would need to voluntarily report it.
Not necessarily. So
no, okay.
If you're not reporting it, it wouldn't be included in your score.
Correct.
But because so much of what they do is, I mean, you'd have to be reporting at least some because those timely and effective care measures, that's where most of those fall. But if you meet the threshold for the claims-based measures for mortality, they will still calculate a score for you if you have at least 3 measures in at least 3 areas. So if you meet that without reporting some of those new measures, you could still have a rating calculated.
Okay.
Yeah. I think a lot of those measures are relevant, so I would be encouraging you to think about reporting them. But that's sort of, so they basically draw from whatever is available. So if you didn't report it, it wouldn't be available for you.
Mm-hmm. Okay. Thank you.
Yeah, it's complicated stuff.
So Carla, this really goes to a question when Jen was talking. So in a sense, you don't have to submit your data to NHSN. You could still get a star reporting, but your percentages would be weighed differently than that safety of care because you still meet your claims based on readmissions, mortality, et cetera, et cetera.
Mm-hmm. Yep.
And that's what I thought. I mean, I've talked to this group before. You know, a couple years ago, we fell to a 1-star due to lab ID, C. difficile. Put a lot of work into it. But I think people really don't understand, you know, as critical access hospitals, this is all voluntarily. And I could have opted, or we could have opted not to report to NHSN and probably have a very high star rating because of our age caps, mortality, and readmissions. But then that's really not that true reflection transparency when you're looking to apples and, you know, and fruit. So we opted to continue to be fully transparent on everything. until finally it dropped off, and we'll have a new star rating the end of this month, which is much better.
Because the data periods hang on for so long.
Yeah, but it took some time. But yeah, it's interesting because I know there are quite a few of our critical access hospitals. Some of them don't report to NHSN, but they still can be part of that star rating if they have that volume.
Yeah. That's also one of the things we raised to CMS as a potential unintended consequence, is that I don't think that they have the awareness that somebody might decide not to report to NHSN because they don't want it to hit their star rating. So we have put that in a couple times in our comments to CMS. So just be thinking about kind of the big picture here.
Yeah, right. Like I said, we still submit everything too.
Yeah.
But if you really looked at it, yeah. Yep.
Yeah. And you would really have to be playing a long game. I mean, the data periods are so long.
Years.
So
and
yeah.
it's not really about
no,
and it's
I
not
know.
really about the game. It's really about patient care.
I know. And I know you guys had a
that's
lot
really
of
what it is,
conversation
and the
about
quality
that.
of care, but sometimes that does fall out. So it goes back to the patients, but I know there are quite a few that don't report into NHSN.
Yeah. No, I applaud you guys' transparency and encourage everyone to consider the same. The star rating is what it is. It's a sometimes not very good cookie. Yeah. Other questions, comments? We haven't gotten cut off yet, so any thoughts about
Maybe
how
they
folks
fixed
are
me on the
using
back
their
end without.
results? Yeah.
They may have
Do any
fixed
of
me
you
on the back
use
end.
the reports? How do you share them with your others in your hospital, with your board, or do you use them to help kind of align or think about your quality improvement activities?
So we're a system, and so 4 of our critical access hospitals are part of the 7, and so the system compiles like all the reports like a summary, and so we know where our leverage points and where it's not, and then but it is used in our QSC overall strategy and making our key metrics in our organization. The CMS 5-star report is a main factor, and I can see with some upcoming metrics how we have been shifting some of the work we're doing in PSIs and different ways, because they want all of us to be 5-star hospitals, right? So you can see strategy wise what metrics we're focusing on as a system, based off where this report is going and where we're at. And we luckily, for the first time, did get a 5-star for being a critical access hospital. So another community hospital in their system were the only ones that had gotten it the last release. So it can happen, you know.
Yeah, there's definitely 5-star critical access hospitals.
Yeah. So
absolutely.
we use this information, and they do use this as a driver for being best in the nation or the top quartile in the nation as a marker using this report.
Okay. Thanks, Barbara. Yeah. Others use it to help drive any kind of quality structure or strategy, or any lessons you've learned when you have to try to explain this to other people in your hospital or your board or your community?
We use it to set our thresholds for left without being seen and the ED throughputs.
Yep.
So it's really handy for that. While I have you, can I ask a quick question about the readmissions?
Yep.
You mentioned the voluntary submission. Can you expand on that just a little bit more?
Yeah, so readmissions, all the readmissions measures have been traditionally just calculated using claims only. So what they're doing with that hybrid all-cause readmissions is that they're going to take that clinical data that you submit, and then there was linking elements like name and Medicare ID kind of thing, and they're going to combine that clinical data with the claims data, and then they'll use that combined data set to have more accurate risk adjustment. So the number of readmissions obviously doesn't really change, but the rate and how they risk adjust some of those calculations. Because right now the risk adjustments are only based off of claims. So they're taking that clinical data to essentially make it a more accurate measure with the risk adjustment. Does that make sense?
Yeah, and you said if we don't submit voluntarily, we will not get.
Yeah, so they are starting to require it as the part of the inpatient quality reporting program. So I don't remember the exact dates, they're in the slides. And once it's a required for the PPS hospitals, they're no longer going to calculate or publish the claims-based only for that all-cause readmissions measure. So at this point, they haven't said they're going to do that for the other. So right now there's, they do the overall readmissions measure, but then they also have the heart failure, the pneumonia, the COPD. At this point, all of those condition specific readmissions measures are still being calculated claims only.
Oh, thank you for clarifying. I didn't catch that part.
Yeah, it's a lot. There's a lot of moving parts. And I'm really glad that you mentioned the ED measure. This just came out last week, so I don't have any slides on it yet, but the outpatient proposed rule came out last week, and they are actually proposing to remove the left without being seen measure. So only proposed at this point. So they're proposing to remove the left without being seen measure. There's some proposal around if you do cataracts, there's a voluntary measure that's around patient visual function. That's a patient reported outcome measure. And they're going to readopt, or they're proposing to readopt the hospital outpatient volume on selected outpatient procedures. Some of you, if you've been around for a few years, might recall that at one point there was you would submit how many outpatient procedures you had. They're reinstating that. There's a patient reported outcome, the same thing that's in the inpatient around elective hips and knees that they're proposing. So most of it aligns with what some of those conditions where you might have inpatient or outpatient, they're sort of aligning one of those, but I know that the left without being seen is an MB-QUIP measure. So wanted to highlight that is actually, we'll see if they actually remove it. They don't always follow with what they originally put out. They take the public comment and then they may come out with the final, but at this point they are proposing to remove the left without being seen measure. So, hot off the presses, the proposed rule came out last week. I just finished looking at it yesterday, and I only look at part of it. So these proposed rule guys are like 1,000 pages because it's everything. It's how everything gets paid for. There's a lot of information in there, and I only look at the quality stuff. Other questions? All right, Amanda, to you.
All right. Well, if nobody has any other questions, we'll give you all back a few minutes of your day, 9 minutes. But thank you so much, Carla, for your presentation. It was fantastic, really well appreciated. I've recorded the session and we'll make sure to get this up on the website along with the PowerPoint presentation and the link that was in the email. I'll get that up on the website hopefully by next week. But thank you again for everyone for attending. And thanks again, Carla, fantastic presentation.
Yeah, lots of links in there for more resources. And feel free to let me know if you have questions.
Thank you very much. You did a really great job. Thank you.
Thanks,
Thank
everyone.
you. Thanks, everybody. Enjoy your afternoon.
Bye.
Bye.